Hello, everybody, and welcome. Thank you for joining us for today's National Alzheimer's and Dementia Resource Center webinar series, sponsored by the Administration for Community Living and hosted by the American Society on Aging. My name is Julia Burrows. I'm the program coordinator with the American Society on Aging, and we will be getting started in just a moment. Before we do, we have a few housekeeping notes. The slides for today's presentation are available under the tab on your screen labeled Resources. Under the tab labeled CE Application here, that is where you will find information on how to obtain CE credit for today's event. You have 60 days to complete that continuing education application, and it may take up to 30 days from the date of your application for us to process and issue your CE credit. If you are not logged in directly to this webinar, that is if you're not using an individualized confirmation URL, you will not be eligible for a continuing education credit because we have no way of tracking your online attendance. If you would like to receive continuing education credit, please be sure to log in using your confirmation URL that you would receive after you register with your own email address. If you have any questions during today's presentation, you can send those to us at any time using the questions box, and we will save the last 10 to 15 minutes of today's program. So now I would like to welcome and turn it over to today's moderator, Sari Schumann of the National Alzheimer's and Dementia Resource Center. Thank you for being here.
Thank you so much, everyone, for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Wisconsin's Dementia Care Specialist program, a statewide effort to support people living with dementia, their family caregivers, and their communities. This webinar series is supported by the Administration for Community Living, and before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. On behalf of the ACL, I want to thank everybody for taking time out of their busy schedules to join us today to learn about Wisconsin's Dementia Care Specialist program. We want to thank Carrie Mulkey and Kristen Felten for sharing their wisdom on the development and dissemination of the program. We're excited to hear from them. Before we move to the webinar, I do want to introduce, we have a special guest today to speak about the 10th anniversary of the National Alzheimer's Project Act. We're joined today by Dr. Tisa Marie Sherry. She's the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy in the United States Department of Health and Human Services Office of the Assistant Secretary for Planning and Evaluation. Dr. Sherry is a health economist and a general internist whose research investigates healthcare delivery, financing, and policy strategies to improve health and economic status of adults with chronic medical conditions, in particular mental illness, substance use disorders, and disabilities. I want to thank you, Dr. Sherry, for joining us, and I'll turn it over to you for some words on the NEPA. Thanks.
Thank you so much, Erin, and thank you so much to our partners at ACL, NADRC, and also in the state of Wisconsin for this opportunity to learn about the incredible work that you're doing. As Erin mentioned, I work in the Office of the Assistant Secretary for Planning and Evaluation at HHS. And one of the really terrific, exciting things that my office, which is Behavioral Health, Disability, and Aging Policy, gets to do is coordinate implementation of the National Alzheimer's Project Act across the federal government. And the National Alzheimer's Project Act has a number of exciting components, one of which is the Advisory Council on Alzheimer's Research, Care, and Services, for which Carrie Mulkey, one of our presenters today, serves as the chair of our Long-Term Services and Support Subcommittee. So we have the pleasure of working with and learning from her there. But also, we put out an annual national plan to address Alzheimer's disease, which describes the tremendous amount of work that's happening across the federal government to address Alzheimer's disease and related dementias. And as it just so happens, this month we are celebrating the 10th anniversary of the national plan. We could not be more excited about this, and we also could not be more excited about the timing of this webinar because we think in so many ways it highlights the progress and the promise of our work on the National Alzheimer's Project Act. The federal government has made tremendous progress in efforts to fight Alzheimer's disease in the past 10 years. And I really want to especially recognize and thank our ACL colleagues who have done so much of the essential work to create dementia-capable long-term services and supports and home and community-based services systems over the past decade. They fostered innovation at the state and local level, as we'll hear about today, and they've helped communities develop solutions that work for their specific needs and populations. And so it's really fitting today that we're going to get to hear about one of those grants, an innovation driven at the state level but supported by ACL that has been tailored to communities across Wisconsin. It's also a wonderful time to be hearing more about this program because a key component of it is early detection. We're at the precipice of having more treatments for Alzheimer's disease. But in order to get those to the people who would most benefit from the treatments, we need to diagnose them early. Connecting with community-based organizations so that we can reach people who are affected before cognitive impairment begins, work to reduce their risk factors to delay progression of dementia, and identify cognitive impairments as soon as there are any symptoms is key. It's one of the reasons why in December we added a sixth goal to the national plan to accelerate actions to promote healthy aging and reduce risk factors. And so it's just so timely and important that we get to hear about this work today. In addition, another reason why we're so excited to learn about the terrific work that Wisconsin is doing is because one of the key goals in our 10th anniversary, looking forward to where we want to take things in the next 10 years, is to take our national plan from being a federal plan and make it really truly national in the sense that we're committed to working more closely than ever with our agency partners, states, local communities, and other stakeholders to ensure that we're getting services and supports for people with Alzheimer's disease and related dementias and their caregivers into every single community, to make sure that we're learning from the amazing, innovative work that our partners are doing on the ground, and understanding how we as the federal government can best foster and facilitate those efforts. So for those reasons, I think this webinar could not be better timed, and we are so delighted to learn from the terrific work that our Wisconsin partners are doing. Thank you so much.
Thank you so much, Dr. Sherry. So at this time, I will introduce our speakers, Carrie Mulkey and Kristen Felten. Carrie Mulkey is Director of the Bureau of Aging and Disability Resources in the Wisconsin Department of Health Services. In this role, Carrie provides statewide aging and disability policy leadership and administers a wide array of state and federal programs that aim to support older adults and people with disabilities to live well over their life course. Carrie Mulkey has been in the field of aging and disabilities for more than 25 years, 22 of which have been with the Wisconsin Department of Health Services. We also have with us today Kristen Felten, who is a dementia specialist for the Office on Aging at the Wisconsin Department of Health Services, where she created the Dementia Care Specialist program and brought dementia-friendly communities to prominence in the state. Currently, she directs a Bold Public Health Grant Award from the Centers for Disease Control and Prevention and provides leadership for the Wisconsin State Plan for Dementia. Kristen has worked in the field of dementia care since 1996, where she started as a frontline staff member in an assisted living facility. At this time, I will turn the presentation over to Carrie Mulkey to begin. Thank you.
Wonderful. Thank you so much, and thank you so much for the warm welcome. I'm sitting here actually in awe as I hear some of these words being spit out back at us, and really, really do appreciate the opportunity to share information with you today. I'm also honored. I'm glad that we spent a little bit of time here talking about the NAPA Council. I'm incredibly honored to be a part of that group. It really is an incredible group of people with passion and drive to make this nation a better place for people with dementia and their caregivers to live. I'm also honored to be presenting today alongside my colleague Kristen Felten on the Dementia Care Specialist program. That is a truly incredible program for people living with dementia and their care partners. So we'll get started with a quick overview of their presentation. So Kristen has that up on the screen here for us. So what we'll start with is talking about some of the conditions that were in place, the landscape that was happening at the time that the Dementia Care Specialist program got off the ground in Wisconsin. And then we'll talk about the evolution of the program over time, which started as a small pilot and then is now, as of 2022, a statewide program. We'll talk about how the program actually works, the three pillars that make up this particular program. We'll share with you information about the structure of the program and some stories. We have some stories to share of the Dementia Care Specialist work in action. We'll wind down by sharing some of the lessons we learned and some thoughts about the impact of this program and our hope that you will leave inspired to consider building a similar program in your state. So I will turn now to Kristen to get us started.
Thank you, Carrie. So to describe how the Dementia Care Specialist program began, I need to briefly explain the landscape in Wisconsin prior to the pilot. Several events created fertile ground in which to grow the idea of what community-based dementia support could become if given the opportunity. Many things were happening across Wisconsin's systems of dementia care. The Department of Health Services had received grants from the Administration for Community Living in 2009 and 2010 to explore new ideas and replicate evidence-based programs, which I will discuss in a minute. The Community for a Wisconsin Response to Dementia was convened to develop a state plan, and an analysis of gaps and available resources across the state was performed. Also in 2010, two events involving individuals living with dementia and the crisis response system led to a state Supreme Court decision and a legislative study council. In 2011, a state budget shortfall in long-term care services created the necessity for new ideas to reduce Medicaid spending. All of this led to the opportunity for the Dementia Care Specialist program to come to life. Wisconsin has received several grants from ACL, listed here, that have helped to inform the Dementia Care Specialist program as it was created and as it has grown from pilot to statewide program. I'm sharing the results of the Wisconsin projects funded by ACL, but what I say does not necessarily represent ACL official policy. In 2009, an innovation grant allowed for the development of our memory screening in the community program by funding the pilot study at the Aging and Disability Resource Center of Portage County. You will hear more about Wisconsin's ADRCs from Carrie Mulkey a little later in our presentation. The pilot of the memory screening program was successful and led to the voluntary adoption and eventual inclusion of the program in all ADRCs statewide, even prior to statewide Dementia Care Specialist program coverage. Memory screening in the community and dementia-capable ADRC staff are now components of the DCS program. In 2010, the Department of Health Services received 2 grants to replicate an evidence-based caregiver support program and a multimodal intervention for people in the early stages of dementia. These grants led to the inclusion of evidence-based programming and as a component of the DCS program even to this day. In 2014, DHS received 2 new grants. The first grant provided the opportunity to develop resources, including an online training for family caregivers on many aspects of providing care, including self-care, with videos demonstrating effective responses to common behavioral symptoms. The second grant and its supplement explored 2 evidence-based caregiver support programs looking at barriers to and facilitators of family caregiver participation in evidence-based programming. The results of this project informed the DCS program in expanding the range of evidence-based programs that were included. And in 2019, we received a grant to replicate and evaluate the DCS program itself. Due to the COVID pandemic, the evaluation of the DCS program was delayed, but has proceeded in a new direction. One site has not been able to contribute data yet, but we have a big reveal of some brand new, fresh off the presses data from some preliminary results that we will share later in our presentation. So back to 2011. The opportunity to find funding for the pilot came when our state legislature identified a shortfall in our long-term care system budget and asked for remedies. Many suggestions were made, including to expand the previously mentioned ACL grant-funded Dementia Caregiver Support Program, which has an evidence base of delaying institutionalization for people living with dementia by an average of 18 months when family caregivers are supported using the program. The proposed savings from delayed institutionalization was included in the package of responses supported by DHS leadership. The Dementia Care Specialist pilot program received permission from the Secretary's office to proceed on June 29, 2012. And yes, I went back in my email to find the date. 6 months later, the first 5 dementia care specialists began work.
And now I get to talk about how the program has been funded over what has become a 9-year adventure to statewide-ness. As Kristen mentioned, the first funding for dementia care specialist services came from federal grants that helped us build and envision a collection of interventions and services that people with dementia and their care partners could really benefit from. To bring those interventions to scale, we were able to receive some GPR by tying it to a large-scale effort to reduce costs in the state's Medicaid budget, as Kristen just mentioned. We were able to make the case that these positions, in the end, would save the state money through the interventions offered by the DCS. So the first 2 ingredients for funding success that we found, first is to take advantage of these federal grants. The second is to really tie this work to priority areas that are already happening in your state. While this funding was significant in terms of getting the program off the ground, it wasn't ongoing funding. So, as we do, we looked for ways we could cobble together some funding in the short term. We looked at some underspending that we had in our ADRC funding budget. Any underspending actually that occurs in any of the county ADRCs comes back to the state and is reinvested in ADRCs. And we prioritize this underspending to the Dementia Care Specialist program. And so since the DCSs are a part of the ADRC, we were able to use this source of funding for these specialists for a period of time, for about 2 years, from about 2014 to 2016. This funding, however, is also one-time as well and not a sustainable solution for the long term. So the third ingredient, however, for funding success that I wanted to name is that you got to keep your eye on the long path. So cobbling together what you can was part of our path. However, we always had our eye on a larger vision and mission to create sustainable funding over time. A fourth ingredient to funding success is really found in partnerships and the need to build them and leverage them. In October of 2013, we convened a summit of stakeholders around the topic of redesigning the state's dementia systems to better support individuals with dementia so they could avoid crisis, such as the examples that Kristen mentioned earlier. A consistent theme that was expressed by participants at the summit was around the need to have someone who could help people navigate the complexity of the disease, the complexity of the systems that people with dementia and their caregivers often have to touch on their journey. From the healthcare system to the crisis system to the Medicaid system to care in the community and facility care too. A dementia navigator to help people with questions and issues over the span of the disease. This led to Dementia Care Specialists being incorporated into the Wisconsin State Dementia Plan as a key priority goal for the state. This was important because it rallied partners around the expansion of this program. This process helps spearhead advocacy efforts around a shared mission to expand funding to support the Dementia Care Specialist program. And it was really helpful that we had legislators at the summit, one from each side of the aisle and from both the House and the Senate. It was from their participation in the summit that led actually to the development of a speakers task force on dementia. The bipartisan group of legislators conducted hearings all across the state. And a common theme that was heard through all of these forums, which, by the way, I attended as well and got to listen to all of the thoughtful comments that were shared across our entire state. But time after time, region after region, we were hearing about the helpfulness of the dementia care specialists and an ask to have them in every community. So after 6 public hearings throughout Wisconsin, the Speakers Task Force created the Wisconsin Cares Package, and it was made up of 10 bills that were intended to better support those living with Alzheimer's disease and dementia and their caregivers. And one item, guess what, included funding for dementia care specialists. This was the first time the DCS program was added to the state's budget as an ongoing allocation. So a sixth ingredient to make funding work is to include those policymakers and to find and rally around your champions. So the members of the task force became champions, especially the task force leaders, and it didn't hurt that many of the members of the task force were also on Joint Finance Committee, which led to additional GPR being allocated towards the expansion of the program in the next 2 biennial budgets until in 2022, just this year, the program is going to be statewide, which means it will be available, there will be a person wholly dedicated to dementia in every Aging and Disability Resource Center. We have 47 of them, by the way, as well as within 11 of the state's federally recognized tribes, which is all of the federally recognized tribes. Next slide. And this is just a quick overview, a visual overview of what I just mentioned, so you can click through these items. Oops. The slide didn't appear to show the time frame.
Yeah, I'm not sure why the timeline is not appearing. I apologize for that error in the slide.
No worries.
So we will move on.
Yeah.
Go ahead.
Yep, the last thing I would say, the last ingredient I wanted to mention related to funding is that for us it really required a lot of patience and persistence. It took us 9 years to achieve statewideness. And there are many times that we could have given up. But the more time that went by, the more and more experience we got with the program, and the more and more people that were able to be served who became our strongest advocates of all. So after all of this, I bet you're wondering, what do they actually do? So Kristen is going to take that on next.
Thank you, Carrie. So yes, the DCS program is being described, often is described as being constructed of 3 pillars, but I don't want you to think of silos. I would like you to think of the program more like this image of a spider web. The image represents the program in several ways. The 3 pillars of the program all work together and are interconnected. The program builds person-centered support around the person with dementia and the family caregivers as a unit surrounded by community. And finally, the web also represents the dementia care specialist in the middle who cannot do it alone. All the other water drops are community partners, volunteers, businesses and civic organizations, neighbors and friends, so that no matter where you are in the community as a person living with dementia or as a family caregiver, there is support available along the journey. The first pillar is creating a dementia-capable agency. The dementia care specialists, as you heard, are housed in Wisconsin's Aging and Disability Resource Centers, which have a contractual relationship with the State Department of Health Services. Expectations for the position are outlined in the contract, and these include training for customer-facing ADRC staff to be knowledgeable enough to recognize when a customer may have cognitive issues or a need for caregiver supports and can respond appropriately. The same ADRC staff are also expected to provide memory screening when appropriate. The DCS oversee the memory screening program at the ADRC. The memory screening in the community program is intended to promote a conversation about memory or cognitive concerns. The outcome of the screens and the observations from the screener result in the appropriate encouragement by ADRC staff to speak to their doctor about these concerns. Memory screens are offered by ADRCs upon request in a variety of venues and are always voluntary. Our data demonstrate that people want access to memory screening, with 1,922 screens performed in 2019. The last year we have good data. Screens can be done in a private room at events like health fairs, or as a part of dementia-friendly community or educational events, or when indicated while ADRC staff are performing other services. An example of this would be a spouse is struggling to perform duties the other spouse used to do but no longer can. They contact the ADRC for help finding support, and an appointment is made. While talking with the couple, if the ADRC staff member notices that one may have some confusion or memory loss, they are able to offer the screens as a part of the visit. Connecting people with their physician includes sending the results of the screens to their physician's office with permission. Participating in screening and what happens with the results is entirely up to the consumer, to the customer. I will be providing more detail about the memory screening in the community program, including some data from the pilot later in this presentation. People living with dementia spend the majority of the time, the second pillar is for the dementia care specialist to act as a catalyst to create dementia-friendly communities. Dementia is a highly stigmatized condition that can carry shame or guilt, both for the person living with the disease and for their family caregiver. The symptoms of the disease are something that many people do not know how to respond to, so instead they look away. Couples will lose lifelong friends. The caregiver may feel embarrassed by symptoms and stop going out as a couple. And both individuals can become more withdrawn and even isolated as the disease progresses. Dementia-friendly communities are ones that are continually working to make their communities welcoming and inclusive of people living with dementia and their families. People living with dementia spend the majority of the time with the disease living at home in the community, much of it pre-symptomatic and possibly while still employed. The progression of Alzheimer's disease is estimated to last, on average, 10 years from the onset of symptoms to death, but it can be more. People generally do not move into care facilities until the middle or later stages of the disease process. So, during the majority of time living with the disease, people will continue to do the things they always have, including patronizing local businesses and going to their favorite places. Dementia-friendly community activities include training local businesses to be dementia-friendly. For most businesses, such as grocery stores and restaurants, this is a customer service training on how to recognize when someone may have cognitive challenges and how to respectfully support them in purchasing goods and services. For other businesses, such as banks, a more sector-specific approach is necessary. Information would include what to do when they suspect financial abuse may be occurring and what agencies and resources in the community are available to help. Law enforcement, first responders, and other crisis responders are also a sector that requires specific training beyond basic customer service. So dementia-friendly community training goes beyond businesses. Libraries are great partners for local dementia-friendly coalition meetings and hosting other events. Local government, including City Hall, where tax payments are collected, and also included in this training. Parks and nature centers, museums, religious organizations, civic organizations, recreational venues, concert venues, the list goes on and on. Anywhere where people go. The dementia care specialist can also create opportunities for people living with dementia and their families to stay engaged in their communities, which include memory cafes, an example of which you will hear about coming up shortly. A limitation the dementia care specialists have in providing dementia-friendly training is that they cannot train medical practitioners or staff in long-term care facilities, so not nursing homes and not assisted living facilities. Dementia care specialists are not clinicians themselves, and dementia-friendly community training is not appropriate for professionals providing direct care. But that doesn't mean there isn't plenty to do, because the dementia care specialist is only one person and can only do so much in a day. The creation of local dementia coalitions is an important component of this pillar. Building a dementia coalition local to a community, whether it's a neighborhood, city, or an entire county, will be the engine that drives activity. Based on experience, coalition members will do the majority of the legwork in more populated areas, less so in more rural areas, but they are still very important. The reason that there are so many people willing to step up and become a part of these coalitions is that 1 in 10 people over 65 has a type of dementia. That means other people in their family know someone living with dementia. They may care a whole lot, and some will want to do something to help with the struggles that they see their loved ones experience. Or others, having received support, will want to give back. These family members and friends work in all sectors, and they want to be able to contribute. Recruitment of Dementia Coalition members can come from anywhere. The third pillar is supporting people living with dementia and their families to be able to remain living at home as long as they want. You heard in the discussion of ACL grants that the results from those projects inform the inclusion of evidence-based interventions in the DCS program. It is true that when I first created the pilot structure, it was not only to contribute to the cost savings plan, but to provide sustainability for those programs as required of grantees. So, to this day, those programs are a part of the DCS program. Other options have been added, and the current requirement of the program is to have at least 2 programs available, with one being an evidence-based caregiver support program, while the other can be evidence-informed or evidence-based, and either for the caregiver, the person living with dementia, or both. Many dementia care specialists have more than 2 options available. In addition to the structured programs, dementia care specialists also meet with individuals and families one-on-one. Many families come to the dementia care specialist because they are in crisis. Something unexpected has happened, something the family cannot manage and needs assistance to deal with, typically involving a medical event or a change in behavior. And then once the crisis or crises have been resolved, the family can decide to enroll in a structured program or attend an educational program or a support group or a book club or a dementia-friendly outing, and decide whether or not to access any of the additional resources from the ADRC or other community partners to provide ongoing support and assistance. DCS also provide education and outreach about brain health, dementia, and caregiving to a very broad audience. Wisconsin has a school curriculum available from our Department of Public Instruction, and some dementia care specialists partner with their local schools to promote brain health through the Advocating for Brain Health Skills-Based unit for middle and high schools. This unit also talks about caregiving because kids are family caregivers too, caring for grandma after school, or perhaps mom has young onset Alzheimer's or another type of dementia with early onset in middle age. Whether it be working with students or helping a family caregiver deal with grief from losing their spouse, DCS work with anyone across the lifespan. Whether it's a person interested in learning more about lowering their risk, if it's someone who just needs to figure out how to deal with that one thing their spouse with dementia keeps doing, or an assistance in making the decision to move to a long-term care facility, dementia care specialists provide community support across the journey with dementia. And now I will pass it back to Carrie.
Great. Thank you, Kristen. For this slide, we just really want to make the point that DCSs are not state employees. The Department of Health Services, actually us, we contract with counties to operate ADRCs, and the DCS program is one of the services that are included in our state-county contracts for ADRCs. Next slide. Aging and Disability Resource Centers are a national program that started in Wisconsin in 1996. Some states have no wrong door systems versus ADRCs, which are similar but are also different. And every ADRC or no wrong door model is a little different too across the country. I elevate this point for 2 reasons. First, not all states have the same infrastructure that we do here in Wisconsin to easily place DCSs and ADRCs. However, every state has an aging network and other community assets that might be tapped. The second reason is that national investment in a more robust ADRC model that includes services beyond streamlined access to the publicly funded Medicaid system can have great benefit for people with dementia and their family caregivers and provide a home for dementia specialists. ADRCs in Wisconsin are one-stop shops where people can find unbiased information related to aging or living with dementia or disability, and there's no means test. We serve people of all incomes. Most services are provided in people's homes, but there are also locations that people can visit. The majority of people served by ADRCs in our state, more than 85%, are not eligible or do not enroll in a publicly funded Medicaid long-term care program. They receive long-term care options counseling, information and assistance, caregiver support, respite, health promotion information and classes, food and nutrition information, housekeeping and chore services, housing options, transportation options, and the list goes on and on. And it does include access to public benefits for people who do require that level of assistance. This means that people who work with the DCSs have easy access to all of those things too. By having staff dedicated to dementia, the ADRC can ensure robust dementia services, and by having the DCS and ADRCs, it can ensure people have access to a broad range of ADRC services too. So that's my shameless plug for more ADRCs or more robust ADRCs in this country. Next, we're going to share some stories of the DCS in action, and Kristen's going to start. And you did not unmute yet.
Thank you very much, Carrie. So one of my favorite stories that I like to share involves a story from one of our ADRC dementia care specialists who had provided the memory screening themselves at an event. About 6 weeks later, the individual that she had screened came up to her in the grocery store and said, "Oh, thank you so much. I went to see the doctor like you recommended, and guess what? He gave me a B12 shot, and it's like the fog has lifted. The confusion has gone away," because there are many things that can cause memory loss and confusion in older adults that are not necessarily a disease or a condition that causes dementia. There are many things that can be cleared up or treated by a medical evaluation. So that's one success story about our memory screening program where an individual was able to receive treatment and return to baseline. And I will turn the next story over to Carrie.
Great. This one I love too. So dementia care specialists are so helpful, as Kristen has been talking about, in building the community conditions where people with dementia can thrive, creating memory cafes or other dementia-friendly community initiatives. One of the dementia care specialists had started a choir in her community. She had, on average, 50 people with dementia would come together on a regular basis to sing and perform for their community. The group was called Stand in the Light Memory Choir, and it's after a beautiful song. That name is after a beautiful song that encourages people to be brave and stand in the light and be who you are. When the pandemic hit, the DCS kept this choir going, turned it into an online forum using Zoom, and seeing these folks come together in their little Zoom boxes and sing together was really, really powerful. The DCS came up with incredible ways to continue to engage people with dementia and their caregivers during the pandemic. They were such an instrumental part of keeping the ship afloat when we were all becoming more isolated and disconnected from our communities.
Yes.
And then Kristen's going to tell the next story.
Yes. So isolation is a really very real thing for individuals living with dementia and their caregivers. So I wanted to tell you the story of one of our memory cafes. This is a memory cafe that was started by the Alzheimer's Association, actually, in the southeast part of our state. And a memory cafe, for those who do not know, is simply a space in a publicly accessible area where people tend to gather for social activities. The space is created to be a memory cafe by making it a safe space for those who have memory issues or possibly dementia and their family caregivers to come together and socialize without the fear of stigma and embarrassment related to the symptoms of the disease. So these are really social outings. They're not support groups, they're not educational events. They're simply safe spaces created for people to be able to get out of the house and continue to enjoy their community and other people's company without fear of embarrassment. So this group actually was people who had younger onset dementia, people who were in their 50s, early 60s, who had been working and had to retire as a result of their diagnosis. And as I'd mentioned before, we're experiencing some of the isolation that happens, that comes along with the diagnosis. The Memory Cafe offered the space for them to come together and meet each other. So there were several of these couples that met at the Memory Cafe and enjoyed each other's company and knew friendships so much that they began to get together and do things together outside of the Memory Cafe. They would go bowling, they would go to baseball games, and they would enjoy their community and their lives. And the reason that it's called the Purple Canoe Club is because after the friends that they had for so long had fallen away, they had found new friends all in the same boat together. Because they were all in the same boat, they were the Purple Canoe Club, and they continued to engage and socialize and enjoy life as into this disease process. Another story that I would like to share takes us back to the beginning of the DCS program, one that involves a person with dementia in crisis. The adult children of a widowed gentleman reached out to the DCS in a small city because they were worried about their father. His children described some of the common symptoms of dementia, but he did not have a diagnosis. He had been living alone since his wife passed away 7 years before and had begun to talk to his kids about the neighbors running machinery at all hours of the night. He told them there was heavy equipment, like a backhoe, digging up the property next door so that he couldn't sleep, although when his kids went to check, the property next door was untouched. His kids stayed over a few nights to be sure there was nothing going on and nothing happened. He then began to approach his neighbors, pounding on their door in the middle of the night. One of his neighbors had told his kids when they visited that she was afraid of him now, but did not want to call the police because they had been neighbors for over 40 years, and she knew him ever since they were young kids. Then he began walking in his backyard at night with a flashlight, looking for the source of the noises and the vibrations he felt, with a loaded gun. No one wanted to call the police on their neighbor. Everyone was very concerned. No one knew what to do. The dementia care specialist was able to help the family navigate the healthcare system while keeping their father safe until he was able to receive an evaluation and appropriate treatment after several weeks. Once the cause, which was a contraindicated medication that had been started, was stopped, he stopped having his hallucinations, and the paranoid behavior that resulted from them also stopped, and he was able to continue living at home. So I promised I would mention more information about our memory screening in the community program, and I will move through rather quickly some information about our initial pilot. It was performed, like I said, in 2009, and as you can see, data was collected from 243 individuals who visited the Portage County Aging and Disability Resource Center. From that pilot, 243 people, 96%, said yes when offered a memory screen. What that means is that people do want to be screened for cognitive conditions. Screening for health conditions is a very common practice, and people are happy to have that happen related to their cognition as well. So of all of the individuals who were screened, 62% received a positive screen. The reason for this is in part where the program resides in the larger system. Individuals who are looking for supports some of whom will need support due to cognitive concerns, will come to the ADRC looking for information and assistance. When the frontline staff at the ADRC are trained to recognize when someone may have cognitive concerns, they can act as facilitators to provide people with information, resources, and encourage connection with a doctor for an evaluation. This means individuals offered memory screens either request them from their own or a family member's concerns, or are offered them because ADRC staff have noticed signs of dementia while providing services. So the group of people who are screened are at higher risk because they already self-identify as having concerns or have observable signs. And as you can see at the bottom here, 80% in this study agreed to have these positive results shared with their primary care physician. So people are open to screening, and they are open to having these results shared with their doctors. The results, we received 50 respondents from physicians participating, and of that number, 47 people had been evaluated, with 39% of those people receiving a diagnosis of dementia or another concern. So, going into our lessons learned about this program, it's very important that the framework be very flexible. The 3 pillars are the framework, but how the program looks is different and unique to each Aging and Disability Resource Center. It builds on the strengths of each individual DCS, each ADRC, and the communities they serve. Locally available resources and opportunities vary greatly across the state, so a one-size-fits-all across the board would make the program less effective. The 3 pillars also work together. You've seen several examples of that. The dementia-capable ADRC is the front door to the DCS program, but also acts as an early detection system for cognitive concerns, also referring to the other pillars. And people want memory screening, 96% saying yes. And there are many reasons that individuals do not receive cognitive screening from their doctors, and reasons that individuals do not want to talk to their doctor. But the results from our memory screening in the community pilot study and the subsequent uptake show that there is indeed demand for screening that is not being met in clinical settings. Volunteer coalitions, dementia coalitions, so very, very important in extending the reach of that one individual providing DCS services. Working with banks, working with park and rec departments, local YMCA, libraries, partners across the community, helping to create that net of support. Tribal programs we have, as well as our county-based Aging and Disability Resource Center Dementia Care Specialists. We have dementia care specialists that are housed in our tribes. And we have learned a great deal since they began in 2015. And what we've experienced are that providing these services in tribes are both the same and different. That it is helpful to start with opportunities around the chronic conditions that are risk factors and to begin there. It is also helpful to include and use plain language, and what you call things is very important. The terminology around dementia is confusing with many different words used interchangeably, so avoiding using clinical or technical language is very important whenever possible, and including what things are called. Originally, our memory screening program was a cognitive screening program, but that was something the general public was less inclined to want. So we changed the name to the memory screening program. Dementia care specialists are sometimes in the tribes referred to as a memory care coordinator because that language is something that is more accessible and understandable within the tribes. They had felt that specialist meant something that was a medical specialist. So to clarify. And finally, family caregivers use the program the most. People who may not have a diagnosis, people who are doing the best they can until something happens, and people who do not want help but end up in crisis are people who the Dementia Care Specialist program serves. So many family caregivers have said, if I had only known then what I know now after struggling for years and finally receiving support. Not everyone may understand the critical role family caregivers play in supporting people with dementia, but remember, the majority of time with the disease is spent living at home in Wisconsin. In Wisconsin, family caregivers provide more than $3 billion in care for people with dementia in 2022. That is predicted for this year. Family caregivers alone, $3 billion in care. So the quick reveal, because I want to make sure we have time to finish up and have questions. The data that we have recently received related to the Dementia Care Specialist program regarding caregiver health is we looked at, in caregiver health, we looked at well-being. We used two scales, the Zaret Burden Scale and the Depressive Symptom Scale. For caregivers who were supported with the Dementia Care Specialist program, at baseline, their average score for families was a 10.46, when anything above 7 is considered high burden. That was 34 out of 39 individuals. At 3 months follow-up, after individuals had been supported with a Dementia Care Specialist program, the average score dropped to 8.3, with 12 individuals considered high risk for depression. So that was a decrease of 34 individuals down to 12. And in the Depressive Symptom Scale, a baseline average score was 16, when a score of 10 is considered high risk, with 17 considered high risk for depression. After 3 months follow-up, the average score dropped to 9.3, with 2 individuals considered at high risk for depression. So quickly wanted to share some of hot off the presses latest data from our evaluation of this program provided to the Hispanic community in Waukesha County and entirely online. So these results that demonstrate improved basically health and well-being for caregivers was achieved in 1 year and entirely online. So I'm looking forward to being able to evaluate the Dementia Care Specialist further in its entirety going forward. And with that, I will turn it back to Carrie.
Great. Thanks, Kristen. So just to close out our presentation, again, make sure we have space for questions. So we started our presentation and really our Wisconsin DCS story talking about the conditions 9 or so years ago that were present in our state that spurred a movement to focus efforts around improving systems of care and support for people with dementia. A moment that was right for the DCS program to get off the ground and grow over time. And this comes after the many decades of brokenness, from the system ignoring dementia as a problem, the years of inadequate resources, broken systems, and the many other times we tried and failed to make remarkable changes to our systems of care for people with dementia. We had good ideas then too, but didn't have the infrastructure to sustain our gains. And that's a part of our story too. It's a part of our shared, collective, national and worldwide story too. So I reflect on the significance of the last decade, how much has happened. So much has happened, starting with an intentional, concerted focus on dementia at all levels. 10 years ago, we didn't have a NAPA Council. Our investments in research were mere pennies compared to other health conditions like cancer. The long-term services and supports system has evolved too during that time. Care and services have grown significantly in this time frame too. We know we aren't even near the finish line, and new issues spring up that we need to navigate and respond to. The DCS program itself continues to evolve as we learn and respond to new needs, and as we see what these amazing people can do. For me, and for all of those who've been around in this pivotal decade and who are here now, all things point to this being an issue of our time, that we need to lead, not just witness. Kristen and I are excited to hear that some states are exploring a program like this in your state too. We're here for you. Let us know how we can help. For us, there's been magic in centering people with dementia into a position, into a person's role and sole responsibility, and placing those people into our communities with a responsibility to serve the community and build community too. They are the backbone that sustains so many important dementia activities, serving as a statewide resource, providing personalized, tailored support for individuals and for changing systems. Some of the systemic impacts that we've seen include things like broad community awareness, early detection, brain health awareness, the level of awareness among law enforcement, decoupling of dementia and mental illness in crisis response. It's been huge. Trivial perhaps, but also significant. During an era when politicians don't agree on much, there was bipartisan support for dementia care specialists in our state. And a favorite, when someone has a need, we no longer need to say, I'm sorry we can't help you, or we don't know how to help you, or contact 10 places to help you. Now we say, contact your ADRC dementia care specialist. Collectively, DCSs have made all of the difference. We want to thank you for listening to us today. We feel like this has been a gift to our state and one we don't want to keep for ourselves. I see this program not just as a program, but as a national strategy for making this country a place where people with dementia have what they need to thrive. Thank you for your time and attention.
Thank you so much, Carrie and Kristen, for your excellent presentation. We're going to move to some of the questions now that have come in through the question and answer chat pod. A lot of these questions are excellent. We'll get to as many as we can. I want to first start off by asking you if you could talk a little bit about the qualifications for becoming a dementia care specialist and what kind of training you may provide.
So we currently require dementia care specialists to have a bachelor's degree as well as at least 1 year experience serving people with dementia and their family caregivers in a professional position. The educational background is quite varied. We have people who come from social work, nursing, gerontology, facility care, all sectors. What we really look for the most is a person with a passion.
Great, thank you. Carrie, is there anything you want to add?
No, I think that's okay for now.
Okay.
Thank you.
Sure. Can you talk, a few questions have come in about the funding. Can you talk a little bit more in detail about how the funding stream has moved, been shaped, and how you, what kind of funding you're sustaining with in the future, how you got to that point?
Yeah, so that, it is a long story, but what I would say is, we really started with a federal grant that we talked about in the beginning of the presentation, and that helped to get the program off the ground. And then we were able, again, because the dementia care specialists are a part of our ADRCs, we were able to use ADRC funding that we had. And in our state, ADRC funding, the majority of it actually is state general purpose revenue. So we have about $40 million of state funding in our aging and disability resource centers. We also have Medicaid administrative funding that supports the ADRCs as a whole. And so given that we have that huge investment in ADRCs, when there is underspending, what we did is we reinvested that underspending into the dementia care specialists to sustain them for a couple years. And then it was really after that we really had to, our partners had to really advocate, and legislators were on board and ended up putting funding into an allocation specifically for this particular initiative, for this particular program, into ADRCs. So the funding, is a permanent part. Well, nothing's ever permanent. I should say ongoing funding is a part of our state budget, and it's in our ADRC line. And it's ongoing, so it supports the statewide system.
Great. I just want to get to this one more question, if you could answer it briefly, about language, and what kinds of tools or resources have you used to ensure messaging is framed in a way where you are helping to draw people in and not making them nervous or making them unsure of accepting services? So I know you talked about changing the language a little bit with the tribal DCS. Are there any other ways that you address language to help overcome stigma?
Yes. So a lot of it is trial and error. But the biggest lesson, I think, is that to use brain health as the title for many things, because more people are interested in maintaining their brain health than they are about learning about dementia, although those things very much overlap and can be the same. So making the positive spin on information and education around maintaining brain health has been beneficial for us.
Great, that's so helpful. Thank you, Kristen. Well, I want to wrap it up today by thanking you both again, Kristen and Carrie, for your presentation. Thank you, Dr. Sherry, again for joining us. And please come again to our next webinar, which will be on July 19th, where we'll talk about emergency response for people living with dementia and their caregivers. And at this time, I will turn the floor back over to ASA for some final remarks.
Wonderful. Thank you all so much for your time and information today. That was a fantastic presentation. As a reminder to our audience, if you would like to claim CEUs for today's webinar, you will be receiving a follow-up email by the end of the business day today that will contain a link to the CEU application. That follow-up email will also contain slides from today's webinar. You have 60 days to claim those CEUs, and again, it may take up to 30 days for us to issue those. And we hope you will all join us again soon. Thank you so much, and take care.